Hello, my name is Dr. Eunice Wang from the Roswell Park Comprehensive Cancer Center in Buffalo, New York. I'm delighted to be here today to provide updates on the current status of treatment modalities and approaches for acute myeloid leukemia based on results from the recent 2025 ASCO and EHA meetings. One of the trials that has the potential to dramatically change the practical management of patients with acute myeloid leukemia was the ASCERTAIN trial presented by Zidane and colleagues at the ASCO 2025 meeting. This trial featured a potential for the first ever all-oral regimen of chemotherapy for older, unfit individuals with acute myeloid leukemia, which growingly have become the majority of patients who are newly diagnosed with this cancer. In this particular trial, the question was whether a combination of oral decitabine cedazuridine combined with venetoclax can substitute for the current standard of care, venetoclax and a subcutaneous azacitidine, for older unfit individuals newly diagnosed with this progressive blood cancer. One of the questions was obviously what was the safety and tolerability of this regimen, but other important aspects of this trial were obviously the efficacy of this all-oral regimen, as well as the deliverability. How feasible was it? Did patients get all of their doses? Was this something that could reasonably be implemented, particularly by our community oncologists who have the strength or the bravitude or the fortitude to treat these individuals in their practices as well. So shown here is the primary efficacy data, and you can see that among 101 older, unfit, newly diagnosed patients with acute myeloid leukemia, that the overall CR rate was an impressive 46%, with a CRI rate of 16%, leading to a CR/CRh rate or CR/CRI rate ranging from 51 to 63%, which numerically is similar to the results from the pivotal practice-changing VIALE-A trial, which employed subcutaneous azacitidine with oral venetoclax. Again, the median time to a complete response was very similar to that study at 2.4 months. And patients who achieved a CR had a median duration, with a median duration of follow-up of 11.2 months, continuing CR about 70-80% at 6 to 12 months after initiation of therapy. Shown here on the right-hand side, you can see the very impressive duration of cure response in these patients, albeit with only less than 1 year of follow-up. What about the safety, morbidity, and mortality with this regimen? Well, you can see that, as we would anticipate with this regimen, the grade 3 and above AEs were reported in the overwhelming majority of patients, and the most common of these, again, as we would expect from the VIALE-A trial, was febrile neutropenia, anemia, and neutropenia. You can see that this led to treatment discontinuation in about 9% of patients, although the majority, 68% of patients, had their treatment interrupted. The majority of these, over 60% of patients, were able to resume, in some cases with some small dose reduction. The incidence of death occurring in the first 30 days was only 3% and 10% and 60 days, again, with some variability, very similar to what we saw in the original trial of azacitidine and venetoclax published by DiNardo and colleagues. What does this tell us? This tells us that this regimen can substitute for azacitidine and venetoclax for the treatment of these patients. And this particular trial has been used to submit to the FDA a proposal to allow for this all-oral regimen to be substituted or potentially replace the standard azacitidine in these patients. So we're waiting right now for the FDA to determine whether this is something that is feasible. I can tell you from my own experience that this would be highly welcome. In many practices, particularly in the subsequent cycles after diagnosis, patients who are elderly and unfit really truly value the possibility of doing this regimen in the outpatient setting. As we know, we don't know how long patients need to continue with this regimen, and this is not a curative regimen for older unfit patients. So for quality of life reasons, transportation, and overall ease of administration, this regimen by far would be a practice changer for our patients if it's approved. The next trial I'd like to talk about was the Quantum First trial, and this was looking at further the results of this upfront regimen in our younger fit patients with FLT3-ITD acute myeloid leukemia. As we know from the Quantum First trial published in Lancet by Erba and colleagues, the integration or addition of Quizartinib, a second-generation FLT3 inhibitor, to standard intensive induction chemotherapy has now become a standard of care for our younger patients with this disease. And that is based on improvement in overall outcomes and survival with the addition of this FLT3 inhibitor as opposed to placebo. However, our question has been, given the molecular heterogeneity of this disease, are there specific patients with FLT3-ITD that particularly benefit from the addition of an inhibitor such as Quizartinib? And we've seen with Gilteritinib in the relapsed refractory setting that there are certain patients that do particularly well with the addition of this FLT3 inhibitor. The Quantum First trial showed only a small overall benefit, but in results presented by Levis and colleagues at the EHA meeting this past June, we can see that patients that had not only a FLT3-ITD, but also had an NMP1 mutation and what we call an epigenetic gene mutation, such as DMNT3A, TET2, WT1, IDH1, or IDH2, had a particularly favorable outcome. And if you look at these curves, you can see that in patients that had this particular molecular profile under the age of 60 years, that their overall survival with a Quizartinib and intensive chemotherapy-based regimen was about 70%, and that this survival curve really plateaued after about 18 months of therapy. Now, why is this important? This is important because in the past, we've always classified favorable risk disease in these younger patients with newly diagnosed AML based on the presence of inversion 16 or translocation 821, those so-called core binding factor leukemias. We're now seeing is that there's a subset of patients with what we would thought would be intermediate risk disease who actually have outcomes that most closely resemble those with favorable risk. So in the future, could we say that patients with FLT3-ITD, NMP1, and one of these epigenetic gene mutations would represent a favorable molecular classification of patients based on their response to a second-generation FLT3 inhibitor and intensive therapy? I think that's on the horizon. You can see that in patients that are older than 60 years of age, there still is a difference, a slight improvement with the addition of Quizartinib over placebo, and that this is maintained over the course of therapy, again, with the curves plateauing at about 18 months. So I think there is still a benefit for those patients greater than or equal to 60 years of age, but really the major difference, which was about almost a 30 or 40% difference in overall survival, was in the younger patient population. What about other regimens for these older patients with FLT3-ITD mutant disease? What about triplet therapy? We've seen triplet therapy advanced for the patients who have newly diagnosed FLT3 mutant disease in the form of triplet low-dose chemotherapy regimens incorporating Gilteritinib, venetoclax, and azacitidine. What about Quizartinib? Could we use Quizartinib, or what about a different HMA, decitabine, again, instead of azacitidine? And so this was the results of a Phase I/II trial performed at MD Anderson that substituted different FLT3 inhibitor, Quizartinib, and a different HMA, decitabine, in combination with venetoclax as a novel upfront triplet for FLT3-ITD mutant AML. And again, these were mostly older patients in the frontline setting. It was a small study, only enrolling about 26 patients. But again, what we're seeing across the board is that these low-intensity chemo and FLT3 regimens are resulting in really astonishingly high overall response rates. About 92% or 24 or 26 patients achieved a complete remission with or without count recovery. About 2/3 of these patients were what we call MRD negative, and the mortality at 30 days was only one patient, which was about 4%. In the past, these triplets have been criticized for the fact that they lead to prolonged time to count recovery. And we do see here that count recovery was about 37 to maybe 40 days. But with the median follow-up of about 17 months, you can see the median overall survival for this unfavorable prognostic category of older unfit patients is over 60%. Now, how is this an improvement? Well, this is an improvement because when we look at the results of the original VIALE-A trial, patients who had FLT3-ITD did not benefit from an overall survival point of view from the addition of venetoclax over azacitidine alone. So the fact that we are able to use venetoclax, azacitidine plus a FLT3 inhibitor and see an overall survival benefit with more than half alive after a year and a half, I think is pretty impressive. Now, this being said, we must not forget the fact that about 1/3 of these patients actually underwent allogeneic stem cell transplantation. But that brings up a really interesting question. In a younger patient with that is fit, maybe we should be thinking about giving them this lower intensity triplet regimen, because we can go back and see, but I can tell you right now that the results of even a Quizartinib 7+3 based induction for that younger patient does not, in my experience, lead to a CRC rate of over 90%. So could we be using a lower dose FLT3 ven-aza-based triplet to get all of our patients with FLT3-ITD or FLT3 mutant disease to an allogeneic stem cell transplant? And this is a key question that is being proposed to be investigated in a couple of randomized trials opening, we hope, in the next several months. Now, what about looking at patients that are not FLT3 mutant? What is the advantage? What should we be doing with these patients? And it's very, very, very interesting. So there was a phase II trial of Quizartinib combined with intensive chemotherapy, but being investigated in our patients that are known to be FLT3-ITD negative, or what we call FLT3 wild type. Now, this doesn't seem to make a lot of sense. I think even dating back to our age of imatinib for CML, we've been very used to, you identify a mutation, you hit it with the targeted inhibitor, and you get improvement and potentially practice-changing favorable outcomes. So how can we now say that this Quizartinib would work in a patient that does not have a FLT3 mutation? Quizartinib is supposed to be this highly sensitive and specific FLT3 inhibitor. Well, it turns out that this phase II trial, looking at the results of Quizartinib with intensive chemotherapy, it actually is based on some early data that we may not be thinking about very clearly. But there was a trial done several years ago by the French consortium looking at the addition of sorafenib, which is also for early generation FLT3 inhibitor, combined with intensive chemotherapy as compared with intensive chemotherapy alone, and all newly diagnosed younger fit patients. And in this trial, interestingly enough, the majority of the patients were FLT3 wild type. And there was shown to be an event-free, although not overall survival benefit, to those patients that got the FLT3 inhibitor, even in the absence of them having a FLT3 mutation. Now, the overall survival was negative, but it brought up the intriguing question, like, these tyrosine kinase inhibitors may have other effects in the biology of AML that could affect them and lead to anti-leukemic activity, maybe not a lot alone, but in combination with intensive chemotherapy could lead to improved outcomes. So there was this trial where they looked at this, and the results of this Quantum Wild trial, which were presented at last year's EHA meeting, demonstrated a clear benefit for patients who were FLT3 wild type in getting the Quizartinib. And when they looked at the correlative data to say what what was going on in the situation. There was a statistically significant improvement in outcomes in patients getting quizartinib. They discovered through this detailed analysis that the gene expression profile of patients who responded to the quizartinib resembled the gene expression profile of patients that were FLT3 mutant. So there was what we would call a FLT3 mutant gene expression profile, or the biology of these patients. Even though they didn't have the mutation, the biology of these patients was such that they were responding to quizartinib as if they had the actual mutation. And so based on this data, this has been proposed to investigate this in, again, a randomized phase III trial. So can we, number one, replicate the results of the phase II trial by seeing whether the addition of quizartinib in FLT3 wild-type patients results in improved survival over 7+3 alone? And can we isolate whether the benefit of the quizartinib added to 7+3 was due to quizartinib being added in upfront therapy and or in consolidation chemotherapy? So this was a proposal that was been of a novel phase III trial, which I think is highly innovative, which is planned for to be opened. I believe it's starting to accrue already at this time at certain sites around the world. Shown here is the schema of this trial. So these are newly diagnosed FLT3-ITD negative patients fit for intensive chemotherapy, who are between the ages of 18 and 70 years of age. All patients will receive a backbone 7+3 regimen, and then will be randomized 2 to 2 to 1 to an arm that includes quizartinib throughout the entire treatment course during induction, consolidation, or maintenance, or to an arm that includes quizartinib only during induction and consolidation, but not during maintenance, versus a control arm of 7+3 with standard consolidation and placebo maintenance. And the questions being asked on this trial is, does the addition of quizartinib throughout the course of the treatment and or only during induction consolidation lead to superior overall survival as compared to 7+3 alone? And obviously the correlative studies will be to collect samples from these patients and see whether we can identify a prognostic or predictive gene expression profile that would show which patients in this age group are going to benefit from the addition of quizartinib, even in the absence of an obvious FLT3 mutation. What are other novel trials that are being done in this space for upfront therapy? Well, not everybody has a FLT3 mutation, but many of our patients may have IDH1 and IDH2 mutations, and those represent another what we call targetable mutation for the treatment of these AML patients, at least in the United States. And so this was the results of a trial, again, done at MD Anderson, where they looked at not only a ven-aza combo, but looked at a combination of a triplet using oral decitabine, this oral venetoclax, and either an HMA or ivosidenib for patients with AML. And you can see here that patients getting an all-oral triplet regimen who had IDH1 mutant disease had very promising results. You can see in the newly diagnosed setting, out of 62 patients, 87% of them treated with this triplet therapy, including an IDH inhibitor, had a response. And about 60% of patients in the relapsed refractory setting had a response. And you can see that the median overall survival of these patients was very good. You can see that it was not reached. Relapsed refractory patients treated with this triplet lived over a year, and patients that had previously been treated for their AML with their MDS with prior hypomethylating agents also did well. So again, looking forward to incorporation of triplet therapy across the board. Can we substitute, instead of giving intensive chemotherapy for all of our patients, can we give patients a lower dose backbone and make up for or improve the efficacy of that lower dose backbone with incorporation of a targeted therapy? And can we substitute, instead of the azacitidine, sub-Q or IV decitabine, an oral agent? What are other oral agents that we have available? We now not only have first generation IDH1 inhibitors, but we have a second generation IDH inhibitor. And this is a trial of olutasidenib, which is a newer generation IDH1 inhibitor, which has been shown to have similar response rates overall as ivosidenib, but for some reason in upfront studies has resulted in a prolonged duration of remission in these patients for unknown reasons, lasting well over 20 months, as opposed to 8 to 10 months with ivosidenib alone. This was a poster presentation at the ASCO 2025 meeting led by myself, where we looked at whether prior treatment with, for example, ven-aza or prior intensive induction chemotherapy would make patients more resistant to this newer generation IDH1 inhibitor used in the relapsed refractory setting. And you can see here that there was a slight, maybe a hint. Patients who had received 1 to 2 regimens in the relapsed refractory setting had a slightly higher overall response rate, maybe 54%, than patients that had 3 or more regimens. But you can see here that these targeted agents in the relapsed refractory setting do still retain activity. And so for patients who've received a lot of prior intensive and low intensive therapy, the response rates are still very decent. You can see that 24% CR/CRh rate versus 41%, median overall survival maybe 9 months versus 13 months. But each of these agents and each line of therapy that we can offer our AML patients is offering the potential for these older unfit patients who can't be cured of their disease additional quality of life and duration of response, which I think is clinically meaningful for my patients. We also had the question, can patients who've had prior treatment with other targeted agents also benefit from olutasidenib? We know that many of our patients, for example, will have co-mutations. We talked a little bit about the co-mutations predicting response to second-generation FLT3 inhibitors such as Quizartinib and Gilteritinib. What about olutasidenib? And this was, again, data presented at the EHA meeting showing that even in patients that had other co-mutations, but had an IDH1 mutation, did have decent response rates to olutasidenib, even with these other mutations on board, some of which are secondary mutations, which typically predict for poor response to standard therapy, but don't seem to be affecting responses to olutasidenib. What does this tell us? This tells us that in the new era of precision medicine, where we're able to delineate mutations not only at diagnosis, but also in the relapsed refractory setting, that we do need to look at these mutations and be looking at what the responses rate and how that can be affected by your mutational profile at every time point throughout the course of your AML therapy. Now, what we haven't talked about now, but we're going to talk about potentially for the rest of this talk, would be the advent of a completely new class of agents, menin inhibitors. Now, menin inhibitors are active in 2 subsets of AML for whom we previously had no therapies. And these are patients that have KMT2 rearrangements, previously known as MML rearrangements, and patients that have NMP1 mutations, which represent up to a third of newly diagnosed patients. Whereas a new agent, revumenib, which was the first in-class menin inhibitor, it's an oral agent which was approved for the treatment of patients with relapsed and refractory KMT2 rearranged acute leukemias based on the AUGMENT-101 study. So just to remind you, there are updated results of this study showing that with longer follow-up, that this really is an active agent, albeit with limited monotherapy results. Among these updated results, again from June 2025, you can see that the overall CRC rate with this agent as monotherapy in heavily pretreated relapsed and refractory KMT2 rearranged leukemias was about 42%, overall response occurring in up to a third of patients, and impressively, that achieving this response, even in the setting of prior transplant and prior venetoclax therapy, does allow about a third of these patients to proceed to allogeneic stem cell transplantation. You can see here that there are, however, a couple things to keep in mind. When you look at these patients treated with revumenib, there are some factors that could predict for outcome. You can see here on this chart that patients who had 3 or more therapies seem to have a lower response rate, lower than 20%, which is a little bit alarming. And patients who had prior venetoclax also had a lower response rate, as opposed to maybe 30 or 40% in patients who had only 1 line of therapy and had no prior venetoclax. How does this influence us? This suggests that if we are going to use revumenib for these patients, that we need to be using it earlier in the treatment course. What about NMP1-mutant patients, the other subtype of AML, which is responsive to these menin inhibitors? 84 patients with relapsed refractory NMP1-mutant disease were treated with revumenib, and you can see again, CR/CRh rates about 26%, overall response rate of 48%. However, the median duration of the CR/CRh rate for both this agent as well as the patients who got revumenib was relatively short. NMP1-mutant patients only had a response that lasted about 4.7 months. For both these patients, NMP1-mutant and KMT2A-rearranged patients, it's important to recognize that revumenib has a very unique toxicity. These agents do induce differentiation syndrome, and that's based on the underlying biology of how they work in these patients. However, revumenib does have a significant risk of QTc prolongation. You can see here about 21% of patients had a grade 3 and above QTc prolongation. It is also associated with some cytopenias and this differentiation syndrome, which we're familiar with from treatment of APL, is associated with high white count, fluid accumulation, and respiratory distress. What do we need to know about revumenib if patients are on QTc prolonging agents? It's something that we have to measure and take into account. These patients require weekly QTc monitoring and EKGs, and there is an interaction with azoles, and so these patients have to be monitored closely with dose reductions with azoles. So is there another agent that we can use, maybe for patients who can't go off their QTc prolonging agents? So there's a second menin inhibitor that currently is up for FDA approval, and this is this agent, ziftomenib. Ziftomenib, in contrast to revumenib, is a once-a-day agent, and in phase 1 to 2 studies, there is no evidence of significant QTc prolongation, and there's no need to decrease or change this agent in the presence of concomitant azoles. So once a week, there's certainly some logistical advantages to this agent. This agent has primarily been developed for patients with relapsed refractory NMP1-mutant AML. And as I mentioned previously, this is sort of the larger of the 2 cohorts that patients that might respond to menin inhibitors. You can see on this phase 2 study of this drug at 600 milligrams once a day, presented at ASCO, CR/CRh rates 23 to 25%. Again, the duration of response in these patients is very limited across all the menin inhibitors, about 4 months. A percentage of these patients being MRD negative. And you can see here that in those patients that did have a response, the median overall survival of responding patients was an astonishing 16 months. So even if they weren't able to stay on the drug forever, they did prolong their survival enough that they could get onto an allogeneic stem cell transplantation, as opposed to patients who were non-responders. So all of these agents have about a median overall survival in the 4 to 6 month range. But in contrast to revumenib, there were similar response rates to patients regardless of their line of therapy and regardless of prior venetoclax. So this might be a better agent for patients that are heavily pretreated and have had prior venetoclax. Overall, very well tolerated. You can see here there is a small incidence, about 13% of that differentiation syndrome, but only 3% of patients discontinuing drug due to adverse events, and no QTc prolongation, and no issues really with azole interactions. So this low response rates, these agents are clearly active in the relapsed refractory setting. So what do we want to do? Well, we of course want to bring these into the frontline setting. So I'd like to talk to you in the concluding few talks here about some emerging data demonstrating really impressive results when we use menin inhibitors in combination in the upfront setting. So this was the BEAT AML trial for older, unfit individuals 60 and above were enrolled to upfront therapies based on their underlying mutational profiles. So in this study, we see there are about 43 older unfit patients who were randomized based on the fact that they had KMT2A or NMP1 mutations to receive ven-aza plus revumenib, just as we've seen before with the IDH inhibitors and the FLT3 inhibitors, adding it to triplet therapy. Impressively, none of these patients had refractory disease when we used this upfront triplet. 84% of patients achieving remission within one cycle, and many of these remissions being actually MRD negative. So very, very high response rates, as we saw with some of the other triplet therapy with the ven-aza backbone. There was evidence of QTc prolongation, as you can see here, occurring in up to 44% of patients had some evidence of QTc prolongation. However, there was no grade 4 events, and patients needed to be carefully monitored. Differentiation syndrome being something, again, that it was not mitigated by the addition of ven-aza. And you can see cytopenias being something that we're starting to see, again, with myelosuppressive effects. Overall, the median follow-up of 6.9 months, some patients going to transplant, but again, a median overall survival ranging in the 15 to 18-month range, 1 year overall survival in 2/3 of patients. What about 7+3? Can we add a menin inhibitor to 7+3? So yes, we have some early data that you can add a menin inhibitor to 7+3, similarly as we do for quizartinib or midostaurin. So this is early data, 71 patients, KMT2A, NMP1 only, receiving ziftomenib plus 7+3 in the newly diagnosed setting. Look at the CRC rate, 92%, 94% of patients having a response, 80% of patients overall achieving a full CR with count recovery, and about 3/4 of patients having MRD negative disease with a response within one cycle of therapy. Were there side effects? There were not with this drug significant evidence of cytopenias. They did have febrile neutropenia, decreased plate recovery, a little bit of differentiation syndrome, but really no significant QTc prolongation, a couple of patients. So again, very, very well tolerated. The number of these patients going on to subsequent allogeneic stem cell transplantation. You can see with median duration, the median overall survival was not reached in either one of these subset of patients. And the majority of these patients, again, with very short follow-up, remain alive. We're continuing to follow these results very closely. There is another menin inhibitor, bleximenib, and which has primarily been studied in the European Union. They have also combined this menin inhibitor. Are these combinations good across the board, across all menin inhibitors? You can see here that when we combine this other menin inhibitor, bleximenib, with ven and aza in newly diagnosed and relapsed refractory patients, we are again seeing overall response rates 80%, 90%. The combination of a menin inhibitor with backbone therapy is very well tolerated, high levels of responses across the board, and interestingly enough, there are some reported menin mutations with these drugs. We're not seeing them with this particular agent. So what are the differences? How are we distinguishing between some of these agents? We're going to have multiple of these menin inhibitors. I think we need to wait and see. You can see that the differentiation syndrome, the QTc prolongation, these are things that we're going to be focusing on in the future. As again, in contrast to revumenib, very little QTc prolongation, very little differentiation syndrome. And so what is going to be the best menin inhibitor moving forward for which patients, we don't know. What we are seeing is for bleximenib, revumenib, and for ziftomenib, as shown here, there are multiple phase III trials that are opening with registrational content. You can see here the example of one of the trials, the KOMET-017 trial, where patients who are fit and unfit are going to be enrolled in 2 cohorts, randomizing them again to receive ziftomenib plus a ven-aza backbone versus ziftomenib plus an intensive induction consolidation plus or minus maintenance. Similar trials have been designed in the HOVON group with bleximenib and with Syndex within the the US as well as internationally. The HOVON group has the EVOLVE trial. There's multiple of these trials that are moving forward, and we're really looking forward to seeing these drugs be implemented throughout the treatment regimen for these patients over the next several years. So with that, I'd like to thank you for your attention, and I hope that this was of help to you in treating your AML patients moving forward.